Welcome to Practical Decisions in Vitiligo Care. Today's webinar reflects our ongoing commitment to vitiligo community, and at Fothera, we're proud to support both patients and providers working to improve outcomes. My name is Katie Neff from Fothera, and I will be opening today's program. As you already know, this webinar is presented by Fothera. Fothera is a leading manufacturer of FDA-cleared home phototherapy devices for chronic skin conditions. Formed in 2024 through the merger of Davlin and National Biological and unified under Madison Industries. Fothera brings over 80 years of combined phototherapy experience. Discover more at www.fothera.com. What an incredible opportunity it is to be here today. Not only is it Vitiligo Awareness Month, but it happens to be Vitiligo Awareness Day today. And we are joined by three outstanding physician panelists who are helping to shape the conversation around vitiligo treatment. All three are valued partners of Fothera, and we're excited to have them with us this evening. I'm pleased to introduce them to you now. Dr. Iltefat Hamzavi is a board-certified dermatologist and co-director of the Investigator-Initiated Research Unit at Henry Ford Hospital, where his work focuses on pigmentary disorders, photomedicine, and hidradenitis suppurativa. He's completed his dermatology residency at Wayne State University, followed by an advanced laser and photomedicine fellowship at the University of British Columbia. He has served as founding co-chair of the Global Vitiligo Foundation and president of the Hidradenitis Suppurativa Foundation. He has co-authored over 300 peer-reviewed papers, garnering more than 20,000 citations, ranking him in the top 0.5% of all physicians for academic productivity. And he has been honored by the American Academy of Dermatology with the John Kenny Lifetime Achievement Award. Dr. Erum Ilyas is a board-certified dermatologist specializing in medical dermatology with an expertise in acne, pediatric dermatology, and photoprotection. She practices in the Greater Philadelphia region and serves as associate professor and chair of dermatology at Drexel University College of Medicine. Dr. Ilyas completed her dermatology training at Cooper University Hospital, where she served as chief resident. She is a fellow of the American Academy of Dermatology, an educator and national speaker, and the author of No Nonsense Skincare, an expert guide to healthier skin, published by Johns Hopkins Press. Dr. Omar Noor is a board-certified dermatologist and medical director at Rao Dermatology and Lucid Dermatology, with faculty affiliation at Penn Medicine, Princeton Health. He also serves as the official dermatologist for the Brooklyn Nets and New York Red Bulls. Dr. Noor has authored multiple peer-reviewed publications and contributed to the dermatology literature across areas including acne, psoriasis, and rosacea. A frequent invited speaker at national and international conferences, he is recognized for his leadership in advancing evidence-based dermatology and improving patient outcomes. Welcome, doctors. Thank you so much for being here. We're thrilled that you're joining us today. Okay, I want to go ahead and get started. I know we don't have a lot of time today, so I just wanted to ground us in NBUVB phototherapy. It's obviously a very well-studied, safe treatment option with strong evidence across multiple chronic skin conditions commonly seen in practice. Today, we're focusing on vitiligo, but dermatologists also commonly use narrowband UVB for conditions such as psoriasis, atopic dermatitis, pruritus, and CTCL. Across indications, it offers a skin-directed long-term alternative to drug therapy. The key question today isn't whether it works. We know that it does. It's where it fits in the modern practice and how home phototherapy really enables more flexible pathways to care. I am going to hand things off to Dr. Noor now. Dr. Noor, can you walk us through how you're currently managing vitiligo patients in the clinic today and where you see NBUVB fitting into that approach?
Absolutely. And thank you so much for having us, and really excited to be able to have this discussion increase the overall education and awareness. Where we start and where vitiligo is today is that even 1/3 of patients that are being diagnosed with vitiligo are still being untreated. And there's a lot of reasons for that. There are patients that, don't feel that there is any treatment, don't want to get treated, don't feel that they could get better. There are providers out there that feel uncomfortable, that don't feel that they have the tools necessary. Maybe there's some lack of education there where they may not know how to get that patient better. And really, this is where phototherapy and understanding our roots in dermatology really helps facilitate that education so that we can help better treat these patients that sometimes have been marginalized for decades, where insurance companies would come back and say, you have vitiligo, this is a cosmetic disorder. And we recognize now, and insurance companies are now getting on board that no, this is in fact a medical disease, and we do have reasonable treatment options for them. So I'm sure, Dr. Ilyas, when you see your vitiligo patients and say, they're coming in and they're a first time patient and maybe they don't even know what they have, how does that discussion go with that patient?
So it's such an important discussion in terms of how you approach it because the real reality with vitiligo is it really asks us something different than many other areas of dermatology. It asks us for endurance with therapy, regardless of what you choose for treatment. Usually success is measured in seasons, not weeks. It's really one of those things that takes months, not days to see success. And since we're so conditioned to see visible wins quickly, vitiligo is one of those conditions that just reminds us that our biology doesn't move on as fast as we'd like it to. It's not on the same timeline. So I really think that that treatment response rewards that consistency. And that's what I discuss with patients is that even though we can try topical therapies and other options, ultimately combining it with phototherapy will give us the best results. And if we play that long game the right way and follow them closely over that period of time, they can often see that success as long as we understand that we set that expectation initially the right way.
Yeah, I love that. I mean, in dermatology, we know that communication is key. As we talk to our patients, if we don't communicate their disease, what to expect, their treatment, and in particular, you're right, with vitiligo, we have to be patient and patients have to be patient. So really addressing that and communicating is critical. Dr. Hamzavi, do you go into the science at all with patients, talking about how narrowband UVB can help to stimulate the melanocytes, whereas maybe some of the topical or oral options or other treatments might be reducing some of that inflammation?
I do. And I explain how phototherapy, narrowband phototherapy, both stimulates melanocyte migration from the hair follicles, but it also suppresses some key cytokines that trigger vitiligo and also have some impact, has some impact on IL-15 and interferon gamma levels, which perpetuate the condition. And in multiple studies, narrowband just by itself in a minority, but a plurality of patients does stabilize vitiligo. And then the VASI score, which is the primary outcome measure for a lot of the studies, was actually first validated using narrowband phototherapy. So the fundamental basis of outcome measures use the fundamental innovation that allowed for much of this to develop. So it works on both pathways, the melanocyte pathway as well as the immune pathway.
Which is critical because if you're not affecting both pathways, your ability to repigment gets even more delayed. And we'll see this with the data that by allowing for the both of these options together, we can actually do better for our patients, which is ultimately always our goal. So we can see here how narrowband UVB, and both of you guys have stated it very nicely, that this has been around for quite some time. But like a lot of things, some things they lose excitement, even though we have yet to have a real alternative to what narrowband is offering our patients. So I think, both Dr. Ilyas and Dr. Hamzavi, you both train a lot of residents and you teach a lot of students and you talk to a lot of other providers. Do you feel that the concept and idea of light treatment has fallen out of favor where a lot of people don't even know that light treatment is an option?
I think that what ends up happening is it might be even more of a resource-driven question, meaning during training, we often do find that we have the resources to teach our residents and trainees about light therapy. They have access to it. But once you're out in the community, the access to light therapy does become a little diminished. And sometimes it has a lot more to do with the ability to offer the therapeutic option for our patients. This is where I find either finding access to light boxes to help patients see that in-office improvement, as well as the option to pursue home therapy, because then if they can actually have the light treatment at home, they might be more inclined to pursue it to keep up with that endurance of therapy.
Yeah, no, the numbers that we're actually seeing are dismal. So on the high end, 50% of dermatologists are treating vitiligo with phototherapy. In a recent survey that we just published, it's around as low as 8%. And I think that Dr. Ilyas and myself, we train people, and the Photodermatology Society, with support of Fothera, has a whole vitiligo training program on their website. And obviously, we have to do a better job, but it really is disappointing. Now, you compare that to Europe, where it's like more than 75%, and you compare that to parts of Asia where they have figured out how to deliver home phototherapy, the numbers are much higher. And so there's a tremendous opportunity to use it. And the other component I want to emphasize is that medicine loves new stuff, society loves new stuff, but medicine lives with data. And we're a rear facing body of knowledge. We can't tell you probabilities on today's technology as far as side effects and benefits, but we can tell you those probabilities much better the further we get from the initiation of that technology. Narrowband UVB has more than 250,000 to 300,000 patient lives tracked for the onset of cancer. We can't say that about any topical or systemic agent. We also have the impact on aging. We also have information on systemic immunosuppression. And yes, there's a little bit of photoaging, not a lot. Skin cancer risk is not being identified. And then internal side effects has been well established, doesn't happen. And there may be a slight reduction in blood pressure. So there's all these benefits that we have from looking at from the data that we have, because it's been so many years since we developed it. And also safety is there. But when something is old, we don't think it really adds value, mostly because we don't have the marketing dollars behind it. So we appreciate Fothera kind of putting some marketing dollars behind this.
Yeah, and which is a very critical component for people to understand that it everything that's shiny and new is not always better. And really, like you mentioned, the safety of light treatment and really the appreciation of its ability to be utilized with the wonderful treatment options that we have now really can help our patients down the line. But the one thing that we can see consistently with this data is improvement. We're seeing roughly 75% of our patients showing improvement with their vitiligo within the first 6 months. So we can feel confident that you're going to move in the right direction. But just like Dr. Ilyas had said, we have to be patient. We have to communicate with our patients to be patient. But remember, this is light treatment as a monotherapy. There are a lot of other tools that we have to use in combination, FDA approved medications, but really we know at its base, the light treatment is going to help our patients. So here's an example of light treatment used in combination with the only FDA approved medication for vitiligo, which is topical ruxolitinib. And we can see here that when light treatment is added to ruxolitinib, we're seeing a 2 times greater repigmentation than when using ruxolitinib alone. Dr. Ilyas, are you utilizing this combination at all in your practice?
Absolutely. And I think it's essential because I almost describe it to my patients as understanding that I think of light therapy as helping treat and manage vitiligo, but also preventing disease progression in terms of topically, when we use topical agents, it's only going to be so effective in the areas that you're applying them. So it can accelerate the repigmentation, but having the light therapy on board can also assist in halting how fast the disease is progressing, which many patients are worried about. You know, oftentimes they might present with 1 or 2 patches and think, well, these are not cosmetically obvious. I'm not so worried right now. but they're always worried about what they could wake up to next. Understanding that we could integrate this therapy with the topicals so they could focus on treating localized areas, but being a little bit more aggressive about being one step ahead in terms of managing overall progress is always better.
Right. Yeah, I love that. And we also see with these studies that there are certain areas of the body that have higher density in hair follicles that tend to repigment faster. So again, that communication is also going to be really helpful. How about you, Dr. Hamzavi? Are you utilizing this combination?
Well, this is actually my paper. I'm one of the
Oh,
authors
well.
on the paper. So we are. And just to be fair to this paper, this was the set of patients who had completed the randomized controlled trial, then entered the long-term extension for another couple of months. But then they were subsequently attached to the combination therapy. And one of the patients is actually from our center, but you see these individuals who had very limited repigmentation after more than a year of topical ruxolitinib. And then you have almost complete repigmentation when they add a year of phototherapy. Now, this was not randomized controlled. This was an extension study, but it is going to be real life practice because that's what we see clinically. When you add phototherapy to whatever systemic or topical agent you're using, you're getting much better results.
Yeah,
And there's been subsequent studies, and maybe you'll have that in the next deck, of
we do.
lucitanib, upadacitinib, systemic dexamethasone. They're much, okay, there you go. So that's a much better
Well,
result.
this is with the TCIs. This is with the
Yeah.
calcineurin inhibitors.
Yeah.
But again, just going back to what you said, when you add the phototherapy to the treatments, we are again seeing a synergistic effect between the
And this
two.
paper, there was a big concern of whether or not adding TCIs with phototherapy would increase cancer. And this was, I think, 15, 16 years ago, this paper. Passeron's was in the 2007, 2006, but it's almost 20 years since those papers were published, and we have not seen that increased risk. So to
Yeah.
your point, combination therapy has data on efficacy better than monotherapy alone, but it's also safety that we have.
So then pushing the envelope with these newer treatment options, like you mentioned, we now are evaluating oral JAK inhibitors for our vitiligo patients. So here's an example of a combination of using phototherapy plus ritlecitinib, which is currently in clinical trials for vitiligo. But we can see here how the combination treatment can be very effective at repigmenting. Because, like you mentioned, Dr. Ilyas, sometimes the topicals are great at focusing on hotspots, but and we're utilizing the light treatment to help minimize maybe potential flares. But what if you have a patient that comes in with a larger body surface area where just topical ruxolitinib may just not be enough?
Yeah, there's an impractical aspect of applying a topical all over. This is where light therapy definitely has a role, but absolutely, if oral agents can be integrated, we'll see even higher success. It's definitely difficult at this point because there's none that are approved for this purpose to see that progress in practice. But it's exciting to know that this is coming our way, and I am excited to see what differences we could make in these patients' lives.
Yeah, and just to add a little Detroit masala to this, this was not a Mount Sinai alone paper. I'm one of the authors on this paper, and we helped develop the protocol, and we were also part of the study. So New York, please stop taking credit for everybody else's work. Now, Mount Sinai was part of this, but it's a New York Knicks thing. You guys beat the Pistons once, and now you think you own the whole world.
Yeah.
But this, again, is an extension study. We don't have all the funding to do randomized controlled trials, but look at the results compared to monotherapy alone. To Dr. Ilyas's point, she's absolutely correct. We are going to get into combination therapy, but what we don't know is how safe is narrowband with systemic JAK inhibition. We just don't know. So this is going to be something that the results will be better. And I'm sure when we do the randomized controlled trials, we'll get there. But even with these studies, which are, again, post randomization, it's a long-term extension study. Everybody got light, and it compared it to the systemic alone. When you look at those areas, better results. But safety, we're still looking at that. But we're going to do this in practice, and exactly as Dr. Ilyas and Dr. Noor are suggesting, stacking therapy is going to give you better results. You will not get the results people want with systemic agents or topical agents alone. you're going to have to add it. Now, please watch for safety. But we don't see any safety concerns right now, but it's going to be some time.
No, and that's very valuable information for us to know because vitiligo is one of those conditions that, like I said, a lot of people will step back from. Almost like what hidradenitis suppurativa was 10 years ago, where people just did not feel comfortable treating it. Vitiligo, with its relative lack of FDA approved options, some people take a back seat to it. We do have a question here from Dr. Mann from Dartmouth. So her question is to either of you guys: do you feel that is there any data that ruxolitinib cream may block narrowband UVB from effectively reaching the skin?
So the vehicle has been compared, and the vehicle does have some reduction of UV penetration, but you shouldn't use the cream right before phototherapy. But there's no impact of the cream after it's applied and then it's washed off. So when we do these treatments in the study, we ask patients to use the ruxolitinib cream in the evening and do phototherapy before it. You don't want to do any topicals beyond mineral oil for topical treatment, just because you don't know the optical properties of the product you're using. So there is a little bit of impact, but you shouldn't be using it right before. But the impact is gone within an hour. So just to be clear about it, this is not a sunscreen. It didn't have an SPF level effect, but it did reduce it when the studies were done.
Okay, but that's very valuable. That's very valuable information, and again, good communication with patients to know that they want to make sure that they're not applying their ruxolitinib cream prior to their light treatment. This is very good. It's a great question. Thank you.
I think that's an important point to make also for the home phototherapy patients, because they may not actually have that guidance when they're at home. When they're in the office, we often can give them or ask them before they enter the light box. However, for home therapy, they may not understand that they should not apply it right beforehand. So it's worthy of the counseling.
And I think that brings up a great next point that, a lot of times we're trained to do light treatment in the office. We did a lot of light treatment in residency. My practices have light boxes in the offices. So like you mentioned, we are very attuned to how our patients are doing after every treatment, adjusting appropriately, really making sure that our patients avoid burning and having any irritation or negative effects from their light treatment. But I know, Dr. Hamzavi, you worked with the Vitiligo working group to help create this guided mode protocol. Can you tell us a bit about it?
Sure. So this is the Vitiligo Working Group, which is a unit of the Global Vitiligo Foundation. And this was a global consensus. And Tasneem Muhammad was the first author right behind me. Her office is right behind me right here. And it was done with John Harris, Samia Aspat from Egypt, Devinder Prasad from India, Amit Pandya from the southern country of Texas at the time. And we had to send out Delphi's. We reviewed the data, but Dr. Cabrera in Chile was probably some of the best data on this. So it looked at how photoadaptation worked, meaning how fast increases would work. We also looked at the global consensus, and we tried to make very simple recommendations. So one, at the time of this, people used to do photo testing. You don't need to do photo testing. Start at 200 millijoules for everybody. And if you are worried or you want them to go up faster and you know they can adapt to light and they've had previous exposure, you can go up to 600 if they're skin type 5 and 6. But vitiligo skin or deep pigmented skin takes on the characteristics from a photo medicine perspective of their baseline skin. It is not type 1 skin. But as a safety feature, 200 is also a safe place to start. But you can't say somebody is 200 when they have deep pigmented skin and their skin type 5, 6 baseline. Secondly, when you're increasing the level, you want to go up by 15%, but you really want to take a look at the degree of erythema. A light pink reaction like a carnation is totally fine, but a bright red color like a New York City fire engine, that is the intensity that you don't want to have, especially if they have symptoms. So it gives you guidelines on what percent to increase, and it does that automatically in guided mode. And then the dosing is a factor. Photoadaptation, the ability to tolerate more and more light, it goes away. It's called UV tolerance at the 1 week mark. So at 1 week, 25%. At the 21 days, 50%. At 22 days, you got to restart that. And so you lose most of the benefit around 22 to 30 days. And the initial photoadaptation studies are done here in Detroit. It showed that in all skin types. So the deep pigmented skin and the normally pigmented skin in skin type 1 to 6. And so this guided mode takes all that information and it just puts it in there and it prompts you to decide which way to pick. And if you want to do a default setting, you can do that. And if you want to customize it to your patient, you can do that too. But it takes all that information, all that experience, and makes it into 3 simple categories: initial dosage, how much to go up by, and then ultimately when to adjust the dose. It also caps your dose, which we recommended at 1,500 for the face and 3,000 for the body, depending upon the skin type.
Yeah, that's incredible. And like I said, you guys have now created a protocol and a system that can help us feel more comfortable if we do, in fact, recommend home light treatment for our patients to avoid all of that kind of negative effects. And what we're seeing here with this study is if you do home light treatment, you have a 3 times higher likelihood of consistently utilizing your treatments for your disease, which ultimately is going to make our patients better. And so we know that if this allows for better adherence, we're going to get better repigmentation. So Dr. Ilyas, you had mentioned that you start your patients quite a bit in the office and then transition to at home. How does that conversation work to the patient or look to the patient?
I think it's presented more along the lines of, once we establish that this is a great option for them and they'd like to combine the therapy, that it gives them a sense of what to expect with light therapy, because getting a box automatically at home can be a little daunting and a little nerve-wracking to decide how to start using it. Once they actually have that experience in the office, gone through it with our staff and know how it works and understand that expectation of seeing increasing energies over time and the time frame, quite frankly, the very first time people get light therapy, one of the shocking things to them is how they're not in the box very long. They say that was only 30 seconds, that was 50 seconds, and they feel like, how could that have done something? So they almost need to understand and work out those kinks ahead of time. So it gives them a chance to really understand how it works. But do understand, I always tell them that you're not necessarily going to see repigmentation in that first few weeks, though. Really, this is establishing an understanding that this is a viable option for you that you think you can integrate into your lifestyle, because integrating it is the hardest part about it, too, setting aside the time to do so. But once they understand that and they think they can do it, that's when I really give them that understanding that this is where you want to resist that urge to interpret those slow results. I actually just had a patient a couple weeks ago who's been getting light therapy in our office for 6 weeks and wants to transition to home therapy now. And she was trying to convince herself whether or not she was seeing results. And I said, you have to resist that urge to interpret that slow progress as a treatment failure. This is not a reason to not progress. This is a reason to keep going. I know we're really action oriented. We always consider when there's gradual progress that we have to pivot, but really with vitiligo, that premature switching just works against us. So we have to avoid that tendency to feel that way, and giving them the understanding that really the challenge is it's not choosing the right therapy, it's staying with the right therapy long enough. And when they really understand that, they can see the role it plays long term.
Yeah, no, I love that. And making sure that this is the best option for them. Dr. Hamzavi, do you talk to your patients about the guided protocol, and especially when you're recommending or sending the home therapy units to the patient?
I do. I also have my own education that I do, but I really use the guided protocol and I use the Global Vitiligo Foundation handout that's on the website, which is the basis of the guided home phototherapy protocols that Fothera is using. And I remind them, you're a Midwesterner, you're from Michigan and Ohio, you're not an East Coaster. We can walk slowly. We actually take care of our parents as they get older. And then at some point, you just take the time. But Dr. Ilyas got it perfectly right. This is going to take some time. And don't look at your skin for 6 weeks. And also, the time that you're in this machine is not what you have to worry about. You have to make sure the dose is delivered of high intensity narrowband UVB. The guided mode takes care of all that for you. It's just the time you have to worry about. And then let us work with you with a good woods lamp to assess whether or not the pigmentation is coming in. But I do go over it. I really think also Fothera has made a major jump in accessibility. It used to be very difficult to get phototherapy, but now accessibility is improved. The instructions are much better, even with almost half an hour of education with the nursing staff, documentation, handouts, the GVF website, people still burn or undertreat. With guided mode, I'm really hoping that will get better.
No, it's a very impressive thing that you have done. And it's even more impressive that the company has been able to create this kind of almost like iPad type of system that allows for patients to easily utilize the guided mode to help minimize that risk of burning and having negative effects. And again, allowing us to have full tracking of every treatment for every patient really gives us a lot of that data, a lot of that understanding that you guys have spoken so highly of, where we can feel confident in the efficacy and the safety with this type of option that Fothera has brought in. And here we can see that Fothera does have multiple options for different patients, right? Because we know that not every vitiligo patient is the same, and there are different tools for different distributions of patients. So where do you find yourself leaning in one direction or another, Dr. Hamzavi, when it comes to recommending these units?
I do, and just like everybody else. So when you want very localized treatment, obviously the Fothera 100 is the way to go. Very easy to travel with, very easy to treat, but you also don't get the generalized darkening of the skin. Because you have to remember that when you're using the full body cabinet, there's a period, as Dr. Ilyas alluded to, where people's vitiligo becomes even more apparent because the surrounding skin becomes deeply pigmented. And if you come from skin type 5 and 6, there's cultural stigmatization and colorization that can also happen, colorism that happens. And that's also going to cause more psychosocial distress. So, but then you explain to them that there's going to be generalized benefits, will stabilize your vitiligo. You'll also more likely be able to repigment larger surface areas. But based upon what the patient's expectations are, their travel requirements, the extent of disease, you can pick the appropriate device. And then the 200, I don't use that one quite as much, but I go back and forth between the 100 and the 600, and for the appropriate patient, they work pretty well.
Yeah, I love that. And I love the 100 for those individual spot patients. There are some patients that have a few discrete areas of vitiligo, and really everything comes back to access. So, Dr. Elias, how has your experience with insurers been and getting patients access to these devices?
Well, it's definitely a process, and it is one of these processes that's another administrative task. However, I do think in recent years it's actually gotten a lot easier through our electronic record system. We use Emma as our electronic medical record in our office, and I understand that it is possible to use other systems such as Epic, but it actually now is a plan under vitiligo. So within our EMR, phototherapy initiation is actually built into the vitiligo treatment pathway. It's actually a selectable plan. So once we choose vitiligo, we can actually choose Fothera home phototherapy initiation as our plan. And there's a series of prompts that's followed with drop-down selections that makes it very easy, very similar to the check boxes that we're probably familiar with getting these products approved from before. It includes things like skin type, device selection, the treatment protocol or light type, narrowband UVB, and if there was any prior therapies attempted, and also if in-office therapy has been tried, as well as that rationale for home therapy use. Once that's completed, our system generates an automatic order that then can be just faxed over to Forthera, and their team takes over from there to take care of the working with the insurance company to get these products approved. It has become far simpler because it used to fall on my staff quite a bit, but now there is quite a bit of assistance for our staff to have those products approved.
Yeah, I mean, it is critical that if we feel this is the best option for the patient, we now have a path to access. And it has, at least in my practice, it has been very easy. And you don't have to have Emma or Epic. They actually have a portal or like a very easy form to fill out on their website that what I would do is because I don't have either, I copy paste the patient information, the address, the phone number, etc. And I put it in this form. I answer the few questions that they have, and it's done. It's out of my hands. I do have to send the note for the patient that day, which is very helpful. So just for their coverage purposes, but it is a very seamless process. Once you do it once or twice, it goes pretty quickly. Dr. Hamzavi, how has your experience been with sending Fothera to patients or sending the light box?
Yep, no, I think that Erum and yourself did a nice job of explaining it. I have Emma in our private practice at Hamzavi Dermatology Specialists. At Henry Ford, we have Epic. It's a little harder with the Epic system, but it's still doable. I would encourage Fothera to kind of get to the point where they can actually deliver the box inside the house. I know there's a liability issue there, but that's probably one of the threats. But it's so much better than it was even 6 months ago. Patients are getting access to it much faster. And as Dr. Ilyas referenced, the burden on my staff was so extensive, and a quarter to half my patients are vitiligo patients. They were getting frustrated because the visit would take me half an hour or so. It takes them hours to get these things. I've done one prior authorization peer-to-peer in the past year. I was so angry, I had to go stick my head in ice for 2 hours just to recover. So I don't think I would want to do what they do. So
That wasn't after the Knicks beating the Knicks beating the Pistons.
I was at that game. I'm still hurting.
Oh,
You had to bring that one up, but we'll
yeah.
talk about
Well,
the national championship next time.
oh, okay.
Um, but no, I think it's gotten a lot better. I think you've alluded to it very well.
I think we have right now about 80% of prescriptions come and get filled. So I know that Fothera is working very hard to change policy along with a lot of other doctors to make sure that we are getting the treatment into the hands of the patients that need it. So that is and has been our goal since the very beginning. And we're consistently expanding access, getting more devices for people, and trying to remove those long-standing barriers that we have talked about in this discussion in a seamless and efficient way. I know that we're continuously trying to change that. And I know everybody mentioned Emma and Epic, and also the form fill that's online. Thank you for mentioning that. Is a very easy way to get prescriptions in, and it's more seamless than it has been in the past. So that all happens quicker than ever. And our team also has been able to step in and take the burden off of your staff to make sure that, again, the patient is receiving care when they need it most. So definitely agree with you all there. I think we're going to run into some conclusions. There was another question. I don't know if you saw it, Dr. Noor.
Oh, yes. So Dr. Hamzavi, if you're utilizing the 100 individual unit and someone is treating, let's say, their face, would you use it in 3 separate timed increments to treat the front of the face and then the sides?
I would, and I would cut the dose down so you don't burn, but you don't want to undertreat either, and because you'll have uneven results. So I would break it up.
I think that's a very valuable tool and very valuable information. And I would say, before we jump into these conclusions, I would say thank you to Fothera. It is webinars and discussions like this that increase education, that allow everyone, our colleagues, our providers that we work with, other physicians even, that maybe didn't have the opportunity to utilize light treatment in residency, to know that this is an option for their patients, so that not if they're from New York, because we're not taking care of our parents, but for everyone else, if you want to help your patients and your patients want to help their parents, know that this is a very safe, very effective option, and we have data to back it up, obviously from the safety perspective, but from an efficacy perspective, even with newer technologies, with newer topical and oral options, we can see the value of narrowband UVB. So thank you, Fothera.
Okay, well, I think that you covered a lot of these, but I just did want to do a quick snapshot of what we've talked about. I want to go ahead and thank all of our panelists. Thank you for taking the time. Thank you for supporting Fothera. We really appreciate you. And together, we are really going to help so many people, and that is invaluable. So, just in terms of our conclusions, we know that NBUVB has been supported for decades. Its ability to repigment and stabilize disease for vitiligo, very cornerstone of treatment, it should be. And patients who are able to maintain regular treatment schedules are obviously, convenience is very important. So right now we think that home phototherapy, there is an opportunity there, whether young or old, life gets busy. It may be difficult to make it into the office multiple times a week, and school, work, travel, family responsibilities. All that is why at-home phototherapy really offers a solution to help patients and stay on track with their treatment so they can see repigmentation. And with home phototherapy and guided mode, we are continuously working to enhance that technology, make it appropriate and accessible on all of our devices. That is our goal, so that people can get treated without sacrificing oversight, safety, and protocol-driven care. So NBVB should be viewed as an ancillary tool. I think we've talked about that today, how great it is, obviously, as a monotherapy for specific patient groups, but it really has an extreme benefit when it is combined with topicals or other therapies. So it's a tool. It's a tool in the toolkit, and it should be used as much as possible. And our goal is really to help more patients receive treatment with fewer barriers, expanding access to evidence-based vitiligo care. So we are just thrilled. Again, thank you so much for your contributions today. And we're going to keep moving forward, keep our patients happy, and we appreciate all of you. And thank you so much.
Thank you, Omar. Thank you, Erum. Thank you, Katie.
Thank you.
Appreciate your time.
Yes, thank you guys so much. I really appreciate it.
This concludes our webinar for this evening. Thank you to our panelists, and have a great night.